um, uh, to this presentation. I'm so thankful to be asked by Alicia to come speak with you all. My understanding, we have just a little bit over an hour, and if we could, we could do like an 8-hour session on this, and we just don't have that amount of time. So I just want to put it forward that, normally I like to do a lot more, interactive sessions, to engage the group, but what my plan is to deliver the information, and then I'll leave it to Alicia, and my email, in case you have any follow-up questions, or a follow-up session, because I do feel like it is a lot of info, and we're all coming at different sort of levels of learning. So please feel free to reach out to Alicia afterwards if there's any kind of questions from the presentation. Um, Please feel free as well to type into the chat, and if I'm not able to answer your questions in our live session, or maybe you're able to stay on the call a little bit longer after, I can follow up either in email or through Alicia. Perhaps Alicia, if you wouldn't mind monitoring the chat, I do see it, but just if you can kind of flag me if there's anything critical to respond to. Otherwise, we'll manage to respond at the end of the presentation.
Yeah, no problem. I'll
So that
manage
would
that.
be
I'm
great.
also gonna pop in a
Okay.
little message into the chat for people
Okay,
joining in.
sounds good. So I'm just going to now share my screen here. And I did check with Alicia that she could hear audio and everything, but I'll just once again, just while I pull this up, once I start here. So Alicia, are you able to see the presentation, the title page? Okay, great. All right, so let's get started. So thank you for the introduction, Alicia. And I can see a few of your faces on screen, so thanks so much. If you're comfortable putting on your video, great. Otherwise, that's okay. So today we're going to talk about pediatric assessment and when to worry, right? This is a huge topic. So let's dive in. So I'm not going to go over my role again, but just perhaps in the chat, to just get a sense for everyone on the call, just to put in, if you're comfortable, your name, role, organization, and your years of experience and comfort with pediatrics. And then I'll get Alicia to kind of just interrupt me and give me a general sense of who we have on the call here. That would be great. So today's objectives are to describe and apply the pediatric assessment triangle, and as we refer to as PAT, talk about our primary survey of a PEDS patient, as well as the secondary survey, and then key takeaways, right? Like those are those big bucket things that we want you to take away. When to worry. So on the screen here, we have a triangle. So this is our PAT, and really, it's you could apply this to adults as well. But of course, we're in the land of pediatrics here at Sick Kids, and you two are managing PEDS patients. So the first part of the triangle is what we call the general appearance. The second part is the work of breathing, and the third part is the circulation. And I want to just highlight that this is a hands-off approach. Okay, so this is even before that a healthcare provider has put on their PPE and actually entered the room, right? So it's about a 30-second quick glance to assess how sick the patient is. And this, of course, will come with experience, right? Depending on if you have new graduate nurses versus experienced. But just to show here, the blue triangle, the acronym TICKLES. So tone, interactivity, consolability, look, gaze, and speech cry. Okay, so that's going to sort of tell you what their general appearance looks like. And it's either good or bad. It's not, it's okay, which a lot of inexperienced nurses might sort of lean towards, right? Then we have our breathing in green. So, what's that rate like? What's the rhythm of it? Are there any retractions? Are there any sounds that they're hearing? And then we've got the red for the color. So your nail beds, your mucous membranes from the door, right? Things like your conjunctiva and whatnot. You wouldn't be able to appreciate that until you got into the room. But we talk about kids who have darker skin tones and how you can tell based on sort of the palms of the hands, the soles of the feet, the lips. Perhaps if their mouth is open, you might see their tongue, right, to assess for pallor. So before kind of moving on, like when I do ENPC, I'm not sure if anyone on the call has taken that certification. But essentially, if one of those identifiers in that PAT, general appearance, work, or breathing, is off, they're considered sick. Okay. And so in that sense, we need to be aware that we need to identify them and assess quite quickly. But if two or more are off, then they'd be considered sickest, right? So just for showing up to your OR or PACU or wherever pre-op, they're considered sick, right? They're obviously coming to the operating room for a reason. If one is off, they're sicker, and if two or more are off, they're sickest. Um, so here we go. There's lots of different equipment, right? And if you're in a hospital that's managing adults as well, you're going to have different size ET tubes. You're going to have different size stylets, and the list goes on, including obviously blood pressure cuffs, right? So it's important that you have the right equipment for these patients for the readings to be accurate, and that your staff know how to use them. I will say, tips and tricks with working with kids, and now having my own kids, it really has come full circle. That really that hands-off approach is key, because kids don't know who you are. You're coming in full-blown PPE. They're really going to get spooked, right? So first sort of hands off, talk with the family, let them get comfortable with your presence and the sound of your voice. Make it a game, right? You don't have to have all sorts of bells and whistles and bubbles and clowns, and right. You can really just have the parents, for instance, take out their cell phone. Perhaps it's a YouTube, video that the kid likes. Other things. You can just start doing a silly dance or singing a song, right? It really will cause the kid to light up and to feel more comfortable around you. Um, and so, as we kind of move through our assessment with our kids, we're first thinking about our primary assessment. Okay, so whether it's in PALS or ENPC, this is something that we highlight. So, primary assessment is the airway, breathing, circulation, disability, or what we know as our neurological status, and expose and environment. And so, is this something that's familiar to you on the call? Just kind of to get a thumbs ups, head nods, right? Um, Okay. I just want to kind of put this out there that if at any point, right, where we're assessing and there's any signs of uncontrolled external hemorrhage, right, if they're coming to the OR, perhaps, they have a massive wound, or they're unresponsive or apneic, this is whereby our alphabet gets rearranged, right? So we would, instead of doing ABC, we would in fact do CABC, okay? Making sure, of course, that we call for help. So, I'll let you sort of know what your own internal call systems are. The one in our ER for our patients would be a red button that says ER response. However, up on the inpatient units at Sick Kids, they would press the code blue button. And so you want to activate that help quite quickly. So this is just a screenshot. I'm not sure what sort of documentation systems that you have at your hospitals, but we use Epic ASAP in our Emerge. And so whether you're paper charting or different kind of power charting, whatever, this is just really to give you kind of a view of what is within defined limits and what would be considered exceptions. And what I teach staff too is just to kind of click on the exceptions so that they know what it is, what's normal, right? And what to look for. So if they're coming to the OR, they're likely going to have something that's potentially altered, right? Perhaps not in their primary, but perhaps in their secondary. So you can see everything here. So, something as simple as symmetrical chest rise, right? If they're coming to you and they have a pneumothorax, perhaps that's not the case, right? So, but knowing to look for that, okay? Really important to highlight, I think, is the D for disability. So, we might think, oh, it's expected that the 2-year-old is going to be screaming and crying at 4 in the morning. They're coming for emergency surgery. They're scared. But we really have to remember that there could be other stuff going on. So not just to chalk it up to, oh, it's just a kid or they're scared. Behavior is a really big kind of red flag for us in pediatrics to look out for with our patients. I talk a lot to staff about what we call end organ function, right? So that's your mentation, right? So your level of consciousness, your circulation or your color, and then your kidney function. So if those are altered, then that's a red flag for us. And oftentimes we see kids with developmental delay. For instance, I talk about a patient who had autism and their parents weren't with them. They presented to us with a gastro picture and in kidney failure, and they were so irritable that we had a hard time getting an IV, and we weren't able to get an oxygen saturation. So going back to basics and asking yourself the why. The kid was a dark skinned child, and so perhaps we weren't picking up the fact that they were a bit pale. But not being able to get a SAT was a red flag. In fact, the child was irritable, not just because they were scared, as we might naively think, but because they were hypoxic and we couldn't get an oxygen reading. So I can't stress the behavior enough for peds, especially in children who are developmentally delayed. Um, or so if you take a look here, you can see this picture, right? So this could be anything. This could be, something like a foreign body. It could be an anaphylaxis, an epiglottitis, but really to not skim over the airway bit, right? Like we need to visualize it. If it's an older kid, get them to actually open their mouth so that we can look in, or we're just listening to the sound of their cry. Maybe it's a raspy sounding cry that we're hearing. Um, and so things like stridor, snoring, gurgling, any kind of tongue obstruction, that's telling us that there is some sort of upper airway obstruction or swelling, right? We know in kids, and I'm sure a lot of you on the call being, in operating rooms, right? I'm sure you've had to do many, foreign body removal with a rigid bronch, right? Like, so I will always say, right, like discharge teaching happens right from the beginning, even in emerge in triage, right? We're talking about safe, sleeping, vaccinations, right? If families have older siblings, right, keeping like all those extra small bits of toys, Polly Pocket, whatever it may be, out of reach, right? So I can't stress that preventative education, even if they're not coming to you for that afterwards, the discharge, right? Um, and so, really, if there's anything sort of wrong at airway breathing, we're going to intervene and then we're going to reassess before we move on. Okay. And I just want to show a couple videos because I don't want to make the assumption that we've all heard the following sounds. So I'm just going to share with you a quick video from Open Pediatrics of Strider. And let me know, Alicia, if do you see the screen here?
Not yet. We can just see your presentation still.
Oh, okay.
And
Okay.
just so you know, Shona, it looks like
Yeah.
we have a wide variety of pediatric experience. We have
Okay.
some new hires in pediatric, up to kind of 20 years experience in
Okay.
nursing and pediatrics, and looks like a variety of hospitals and clinics, and then also some surgical partners as well.
Excellent. Welcome, everyone.
We can
Okay.
see that video now. Yeah.
Okay, perfect. And can you just give me a thumbs up, Alicia, if you hear the video audio? Just to preempt this video, this is a video of a child with stridor.
And stridor is a high-pitched noise that occurs on inspiration and is the noise essentially of the turbulent airflow that the infant is generating by drawing air in through a narrowed area.
Okay, so that was just a real quick sort of video to show you what is stridor, and then just to kind of get a sense, who of you have heard stridor before? If you wouldn't mind just popping it in the chat there. So once again, that's an upper airway obstruction that we would take quite seriously, and not to just sort of jump to
The infant
conclusion
has obstruction
that it is one thing or another. We have to get a thorough history to understand what we're dealing with here. The next video I want to share is one of wheezing. Okay, so this would be considered what we call a lower airway obstruction. So I'm just going to show that with you now. Okay, and then just give me a thumbs up, Alicia, if you hear the audio.
You should be very familiar with is the wheeze. A wheeze is a high-pitched noise that can be heard on both inspiratory and expiratory breaths. If the wheeze is heard on the inspiratory portion of the breath, it often indicates an obstruction in the upper portions of the airways. However, if you hear the expiratory wheeze on the lower portions, it can indicate that there's a lower airway obstruction. This is commonly heard in asthmatics or bronchiolitics. It is a very important note to say that if you've heard wheeze on your initial respiratory exam and that wheeze disappears, be sure that the patient has not lost their ability to aerate at all. Sometimes we're reassured by the absence of the wheeze, but in fact that may indicate that those airways have closed so much there is now no air movement at all through them. Coarse breath sounds are the noises.
Okay, and just in the name of time, I'm just going to keep it just at the wheeze to show, because those are the most common ones that we're going to hear. And then I'll show you here back to our presentation. Okay. Are you seeing the presentation again, Alicia? Excellent. Okay. So those are the two main sounds that I would direct you to. And of course, some of our, for sure, our stridor, you might hear it audibly. Your wheeze, you might hear it audibly as well. But I just wanted to stress that point in the video about if you are hearing a silent chest, to check sort of what their work of breathing looks like, check their, the overall pediatric assessment triangle general appearance work of breathing color, because in fact, they might be so tight that they're not making sounds, or that they absolutely have absent air entry, which is not good. We know that in children, they're not going to have cardiac arrest the same as adults, where they just kind of drop and go into VFib. We know that the two main reasons for a cardiac arrest in children is a respiratory nature, whereby they go into respiratory distress, respiratory failure, and then they would have a cardiopulmonary arrest. And the other one being hypovolemia. So that could be, fluid loss, whether it's from blood or gastro, and I'm picturing being an OR provider, right? And this is all right up your alley, that you're going to be managing this stuff, right? So in PALS, we talk about the reversible causes of cardiac arrest and the H's and T's. Things like hypoxia and hypovolemia are on the docket for sure. Okay, so moving on. These are just some screen grabs from About Kids Health. I'm not sure if you're familiar with this site, but this is a great site. I use this all the time, whether it's with patients, families, or loved ones. It's a really excellent site. It's translated into 10 different languages, and it's got great pictures and whatnot. So you can see here a screen grab of difficulty breathing in an infant versus an older child. And when we say skin sucking in, what does that actually mean to the family, right? So I just wanted to bring your attention to that resource. It's A through Z, and you would just type in whatever it may be that you want to show. So I'm now just going to show you another video.
When the patient has secretions or
here we go. And so this video that I'm going to show you next, so do you see a video, Alicia, of respiratory distress is the title? Excellent.
Yes, we do.
Okay.
Yeah.
So this is really to highlight the importance that, some providers might say to me, oh, they're much better. Their resp rate is now only 40. It was 90, right? And so really making sure that the staff know the difference between respiratory distress and respiratory failure. So I'll just let this video play for you all.
Respiratory distress, we're really referring to the use of compensatory mechanisms to maintain adequate oxygenation and ventilation when something, one of many things, is causing respiratory compromise. Typically, the compensation consists of an increase in the rate and work of breathing. That increase will increase minute ventilation, allowing the child to exhale more carbon dioxide when gas exchange is impaired. Signs of respiratory distress include retractions, sternal retractions, for instance, because of the flexible, compliant breastbone, as well as intercostal retractions. And this is an example of increased effort resulting in muscles exaggerating the spaces between the ribs or in the sternum. Use of accessory muscles, such as the strap muscles in the neck, nasal flaring, and grunting, an expiratory noise that's designed to apply some PEEP. Children in respiratory distress typically are anxious. This is an uncomfortable feeling, and with that stress, they oftentimes have tachycardia. These are some examples as well of signs of respiratory distress. The child who wants to sit upright and is unable to lie flat comfortably. The child in the left looks anxious, and the child in the right is demonstrating increased work of breathing. Respiratory failure, on the other hand, is at the other end of the spectrum and is defined by inadequate oxygenation and ventilation. Essentially occurs when compensatory mechanisms fail to maintain gas exchange. Interestingly, respiratory failure can occur without preceding respiratory distress, meaning it can happen when there is depression of respiratory effort, typically by something like a poisoning, which depresses mental status, or seizures, or severe weakness, leading to inadequate respiratory effort. Signs of respiratory failure when the compensatory mechanisms are no longer able to sustain gas exchange include desaturation or cyanosis despite supplemental oxygen, the appearance of increased effort leading to poor air entry. In other words, lots of work for very little gain. This may be characterized by a sound of gasping when the child inspires, head bobbing, which is an exaggerated form of accessory muscle use in which the head literally will bob as the muscles of the neck and shoulders are trying to participate in gas exchange. Seesaw or paradoxical respirations, where the abdomen and chest move in the opposite ways than they usually do. And sounds of severe obstruction, such as stridor. The hallmark of respiratory failure, to distinguish it from respiratory distress, is a change in mental status.
So I'm just going to stop sharing there. But essentially, I wanted just to play that to make sure that everyone is on the same page with respect to, when to worry, essentially, which is the title of this presentation, right? So, if they're in respiratory failure, we are very concerned, right? As mentioned before, about them potentially going into a cardiac arrest, and knowing that, your kids that are coming to you, they might already be intubated right from the emerge if it was a trauma, but these might also be other kids that have yet to be intubated, right? And they're coming to you and you're seeing them in the pre-op or in PACU. So just remembering to assess for any signs and symptoms of rest distress or failure, whereby maybe the kid needs to be re-intubated again, right? Okay. So just to show here, right, like the exceptions, I'll just kind of stress a few things here. It's with respect to the airway, we have to, make sure that if they do have an advanced airway, is it working? So we talk a lot when I teach PALS about the dope mnemonic, right? Sometimes when we're moving that kid around, there could be a displacement, an obstruction, a pneumo, or equipment failure with respect to the vent. Making sure that that trachea is midline, right? Things like breathing, are you seeing symmetrical chest rise and fall? And do they have good air entry to all their lobes? With respect to our PALS guidelines in 2020, these are the new guidelines. So really important that we know that in infants and children, we have to breathe faster for them, okay? They have a higher respiratory rate. So with respect to ventilation, whether or not it's rescue breathing, meaning they have a pulse, but their breathing just isn't adequate, or whether they have an advanced airway with infants and children, meaning anyone who hasn't hit puberty. So that could be anyone, around 9, someone might have hit puberty. So below that age would be considered infants, children. we would give them one breath every 2 to 3 seconds, as mentioned, for rescue breathing or advanced airway. We're also not saying to do any further cricoid pressure. I know when I practice in bedside, we did do that, but it actually, studies show that it decreases the chance of the provider having the ability to intubate on the first pass. And it also doesn't decrease the risk of regurgitation, okay, or aspiration. So when we talk about respiratory distress and rest failure, what we're really concerned about is that they could have a cardiorespiratory failure, which then could go into an arrest. Okay, so from a circulation standpoint, this is a big one. Okay, so we're always wanting to assess peripheral and central, right? If we have weak, thready, delayed cap refill pulses and cap refill on our patient, but centrally, our pulse is, okay, and our cap refill is okay, that's one thing. But if when we assess, we find that we have a delayed central cap refill and weak, thready central pulses, we're also, now going to be worried that this person could arrest. Although most kids go into PEA or asystole, we do know that they can go into shockable rhythms, right? So I've definitely seen that in my career where they've gone into VFib or pulseless VTAC, just like with adults, right? When they have decreased LOC, okay, 10 seconds just with your basic life support. Try to wake them up, right? Assess for their breathing and check a pulse. So anyone who's, a child up to adult, you would check carotid. In infants, we would check brachial, okay? And if they don't have a pulse, we're going to start compressions. In peds, though, if they have a pulse, but it seems to be less than 60, where maybe, you might have them on a monitor, you might not. What we would advise in PALS is you would, if their heart rate's less than 60, you would provide ventilation and oxygenation, and hopefully that actually perks up their heart rate. But if it doesn't, you're watching them clinically to see if they pink up. And if they don't, then you're going to start compressions. Okay. But it's that 10 seconds quick assessment. And if they do lose the pulse, or despite bagging them with oxygen, they're still less than 60, and we start CPR, you're still doing like you would in adults, right? You would put on the defib pads, and your team leader would arrive once you call for help, and you would assess the pulse and rhythm and ask, okay, is this shockable or not? And if it is shockable, the priority is always to shock, right? So I'm just gonna show you another video here.
Oxygen levels fall and
causes for concern, okay? Here we go. Do you see that screen? Okay, perfect. Here we go.
Some things you should know and when you should be worried and concerned for your patient. Tachycardia, or a high heart rate, is typically going to be one of the first indicators that your child is becoming more ill. Secondly, you'll want to watch for decreased perfusion. As we talked about, the signs of decreased perfusion are going to be poor color, pallor. You may notice some mottling where there's some pale white spots developing around the patient's body. You'll want to look for decreased capillary refill time. You'll also want to note, has your patient become more lethargic or sleepy? A child who is unresponsive to pain should be evaluated immediately and is most likely in an impending situation. In addition, you'll want to watch their urine output. When a child is in a situation where their cardiac output is compromised, your body will shut down the blood flow to the kidneys, and you may see a complete or partial decrease in their urine output or production. This should immediately also be brought to the attention of the care team. Some of the late signs that your child is an impending cardiovascular collapse may be, again, the decreased pain response or total lack of response. They've become flaccid and their tone is low. And finally, they're experiencing hypotension or a low blood pressure or a low heart rate or bradycardia. These are typically impending signs of doom. Again, it is important to note the lack of a central pulse indicates immediate need for CPR and chest compressions, and the emergency system should be activated.
Okay. So just to kind of highlight what I was explaining before about end organ function is what they're talking about there. Once again, I can't stress enough to alert the team by pressing, whether it's a code blue, code pink, whatever code that you would call to have your team come to the bedside. Okay, and someone who's trained in PALS would run your resuscitation. Um, so just showing once again a screen grab of your exceptions to circulation. As mentioned, most kids will go into PEA asystole, and you're just going through your H's and T's, right? But of course, if you're in VFib or pulseless VTAC, we need to shock. If you're in rhythms such as SVT, but you're well perfused, we would do vagal maneuvers, whether that's ice to the forehead. We would, get them to blow through an obstructed straw, tell the older kid to bear down, try to push the plunger out on the syringe. We know that the rate for a child to be in SVT would be 180 without P waves. For an infant, and when we say infant, it means less than 1 year of age, it would be over 220. It's not variable. So we talk about if you give the kid a cookie and then you take away the cookie, the heart rate's still going to be 225, right? Versus a kid who's in sinus tach, you give the cookie, the heart rate's going to come down nicely, right? Versus you take it away, it's going to go up. And it can kind of come on, very sort of suddenly and with just sort of general sort of symptoms, right, of being unwell. Our kids in SVT or VTAC with pulse, if they become compromised shock, decompensated shock, meaning their blood pressure is low, they're poorly perfused, they're, cyanotic, etc., we would then provide synchronized cardioversion. So knowing the differences of your VFib and your pulseless VTAC, which would be immediate shock, right, of unsynchronized shock of 2, 4, 6, 8, 10 per kilo. Our DFibs that we use have CPR feedback. We have what we call CPR coaches who are monitoring the depth and the rate on our kids, and we go to a max of 200 joules on our defibrillators, versus the SVT VTAC with pulse. If they're poorly perfused, we would give 0.5 to 1 joules per kilo and up to 2. I didn't mention also with SVT, we would give adenosine into the right AC, 0.1 per kilo and then 0.2 per kilo, max first dose of 6 milligrams and max second dose of 12. Just remembering, like anything, whether it's adults or pediatrics, in any resuscitation, it's all about team dynamics. So you can have a lot of really intelligent people in the room, but if we're not working together, then it's going to, fall apart very easily. So at Sick Kids, we have what we call Caring Safely, whereby we coach and train everyone to speak up, right? To stop, think, act, review, closed loop communication, three-way call out with drugs, share mental model roles, and define those roles, because that's huge. If we can catch potentially an error before it gets to the patient. Okay, so I've already kind of spoken to this, but I'll just highlight a few things here. We want high quality CPR. I mentioned about how our DFibs have feedback metrics. If yours don't, it's trickier to say visually what, if you're doing high quality CPR. Curious if you can kind of throw in the chat if anyone works in an area that has CPR feedback on their defibrillator. So we want all ages, right? Infants, children, adults to go for 1 to 120. And for depth, I always just train 4, 5, 6, and that's in centimeters. So infants, 4 centimeters, children 5, and adults would be 5 to 6. Okay. So infants less than 1, children are over the age of 1 up until before puberty, and an adult is puberty and beyond. Okay. When we're going in individually to resuscitate, we would be doing 30 to 2 if it was a 1 rescuer peds. And then once it's 2 rescuer peds, we would switch to 15 to 2, but keeping in mind that an adult could be a 9-year-old. Okay, so in that case, we would do 30 to 2 throughout. Now, with that being said, that's with someone who doesn't have an advanced airway. If you do have an advanced airway, not only are you going to not have to stop doing compression, so you're going to keep that coronary perfusion pressure up, but you're going to be able to breathe for them more regularly. regularly, right? Which is, as we talked about earlier, really important with our kids. Um, infant compressions, I'll just highlight in 2020, it came out that, we can use the heel of one hand. So when I worked bedside, this wasn't the case. We, did our 2 fingers, we did our 2 thumb encircling, but now we can say you can use the heel of one hand for an infant. And as said, we want to go 4 centimeters. If you have the feedback on your defibrillator, you should be compressing to that. So this is just to sort of say that, with the younger kids, their heart rates, their rest rates are going to be much faster and quicker than yours and mine, and they're going to slowly get less fast as they get older. But your vital signs, it's good if your staff have sort of like a little quick pocket card, whether it's their PALS card or an internal kind of card to refer to, because we really need the staff to use their critical thinking, their knowledge, skill, and judgment to ask themselves, do these vitals make sense, right? And it's not so simple to say, oh, they're tachycardic because they have a fever. There could be other stuff going on, right? It could be because they're losing, in your case in the OR, right, blood loss, and so on and so forth. I won't kind of go over this too much, but this is just a quick list, not exhaustive, of why someone's vitals might be altered. Okay, you're all probably dealing with patients for many reasons, and it would be good if you could throw in the chat what are the main, I would say, let's say top 3 reasons why you're seeing these kids in the OR. But I'm looking at things like head injury. I'm thinking of maybe like orthopedic injuries, or any kind of abdominal stuff, right? Like, so, an appendicitis or something like that. And Alicia, you can interrupt me at any time to add to it. But so disability, I'm just aware of the time, so I'm just going to push through. As mentioned, behavior is a big one, right? So EMS will use things like AVPU. I don't know about anyone on the call. It's really hard to memorize that GCS scale, right? We all know that the lowest is 3, the highest is 15, and if it's less than 8, intubate, right? But the nuances of it can be hard to remember. So EMS will use AVPU with respect to sort of their LOC. I will kind of sort of show here, this is sort of how we would elicit a response. I'm sure many of you are aware of this. I will say that pupils are a big one, right? And that's why it's part of our primary assessment. A quick check of their eyelids, right? Or, if there's a blown pupil, call for help. And then at Sick Kids, we talk a lot about SBAR, so situation, background, assessment, recommendation. So if I called for help and the team came in, the first thing I would say is blown left pupil. And that would signal to my team, okay, let's call neurosurge stat, right? Let's do, if we're thinking that this could be a bleed, right? Let's get some 3% saline, reverse Trendelenburg. If this is a trauma, call CT and get them up to the OR. Let's intubate them, etc. I just wanted to show that someone who's less than 1 can still get 15, because although they don't talk, they're smiling and cooing and crying appropriately would give them a 5 for verbal. Okay. These pictures here, I've seen this many a time in my career. So decorticate versus decerebrate. So if I were to throw a ball at you, your initial reaction would be to do this, to try not to get hit by the ball, right? So the decorticate posturing is a higher level number on your GCS than the decerebrate. Both are not good and they're abnormal, but the decorticate is a higher score than the decerebrate. I've seen both of these, and it might just be very subtle, right? That you notice this on the table. And that's why it's important to expose the whole patient. And so you can see potentially their feet that are plantar flexed, right? I kind of mentioned this, but when you're assessing that kid's neuro status, you can turn it into a game. I used to say to them, hold up the pizza box, tell me what it smells like, what kind of pizza is it, right? To see if they have any pronate or drift. I will say with the little guys, I'm not sure if anyone on the call has ever seen sunsetting. If you want to put in the chat if you have, I've definitely seen that many a time. And so just to kind of highlight, pre-COVID, everyone would shake hands as an adult, right? When you'd introduce yourself, but maybe not so much now. Maybe it's like the elbow hit, but on kids, we talk about the pediatric handshake, right? So to put your hand over the fontanelle to assess for if it's bulging, if it's sunken. Okay, so this is a picture of of a child with hydrocephalus. You can see the imaging on the right, and what I'm wanting you to see is how the gaze, right, is down, similar to a sun that's setting in the horizon. You're not seeing the full sun or the iris or pupil on this child. It's being pushed down, and you're seeing a big part of their sclera. So that's abnormal. And if you were to see that irritable, high-pitched cry, bulging fontanelle, this is a medical emergency. Depending on where you work, of course, you might have to patch out to get Orange or Axe or whoever to come pick the child up, and perhaps they're coming to a tertiary care center such as Sick Kids, whereby they would potentially need to undergo, surgical neurosurgery, right? And so assessing, kids and the size of their head, right? Like that's done often at their GP, but perhaps they don't have access to care, right? Perhaps they're, they don't seek medical care. They don't have the means to do that. So just to be aware of things such as measuring their head circumference. We're still at primary. So E, right? So expose an environment. So this is big, right? So, the kid that's coming to you with the appendicitis, maybe there's an element of abuse that's happening at home. And maybe we've overlooked it in Emerge because we're just kind of trying to really keep everyone's head above water, right? And we overlook the fact that there was fingernail marks, down bilaterally across the sternum. Okay, so or a circumferential burn, bilateral burn, etc. Right? So there's red flags that we have to look out for from a safety perspective for kids. So that's why exposing them and really looking, is that a Mongolian spot, or is that a questionable, like non-accidental injury? Okay, I will say that with the neonates, they get cold quite quickly and they drop their sugar quite quickly when they're stressed. So, in your ORs, if it's really cold and, it's a neonate, be thinking that that's going to affect them, right? So thinking about, warming the room so that you're not playing catch up with their temperature, their sugar. When we talk about vitals, it's really important with kids, especially in the OR, that we have the right weight. And so, we might say, oh, it's a 20-kilo kid, and we're going with it. We're all on the same page. We're drawing up drugs for it. But in fact, they're 20 pounds. Okay. And I've been in a situation where that's happened. So just double check. And, some hospitals, you might use Broslow tapes. That's a good one to use. And of course, the best practice would be to actually weigh the child. But if this kid is coming into you from Emerge, they weren't weighed, it was a trauma, right? You don't want to replicate the error potentially of overdosing with drugs or underdosing, right? Family presence, I can't stress this one enough. The family is who they say it is. It's, it's really, it could be anyone, right? It could be the neighbor that's considered the family, right? So just be open to that and know that we want to keep them in the room if they want to be there. Obviously in the OR, they're not staying, but here at Sick Kids, we do, go over with child life workers. We have, different kind of videos and pictures to show them what the process of the OR is, right? And sometimes, obviously, we have to speak with the team in the OR and the anesthetist, et cetera, to see if the child, let's say, has autism and is highly stressed, if the parent can go into the OR until the child gets their induction, right? This is obviously not something that we would necessarily be able to do with all. And, in an emergency cases, it's challenging. But, I remember one time, having a child who, it was a drive-by gunshot to the head, and the patient wasn't the target, but just happened to get the gunshot to the head. And we were running to get this kid to CT and running to get to the OR. But, I advocated as a nurse to ensure that we did a quick stop by with the parent, to give their kid a hug and a kiss goodbye, because what ended up happening was the child did succumb to their injury. So take a moment to just kind of pause and say, hold on, I know this is an emergency, but can we let that family give them a hug and a kiss? Because now as a parent, it's much different to me, but I just really, that's a big one for me, is to really support them. And if it's you're in the PACU or pre-op and they have a cardiac arrest, to not push the family away, to actually invite them in with a support person. If they don't want to be there, then of course we don't want to force that upon them. But if they do want to be there, it does help with their coping afterwards, right? That they saw that we did everything that we could for them. With respect to the following, so G, so get adjuncts, give comfort. I won't go into too much depth because I'm aware we're getting short on time, but this essentially goes through all of our other things that we want to cross-check. So our labs, our monitors, things like nasogastric tube, we're not putting those in anyone who has facial trauma, because we worry about things like a basilar skull fracture. We want to decompress the stomach so that we're able to bag them properly. We want to confirm placement as well, though, right? So you might, get an x-ray when you intubate them, and then you might also get the x-ray of the tube, or you might do a pH test, but we're not confirming via pop anymore. That's not evidence-based. Things like our oxygenation and tidal CO2, that would be inline monitoring if they're intubated, and looking at those on the screen just like you would the other vitals, and speaking up if something is altered during the case, right? Pain, we want to assess not just with pharmacological but non-pharmacological. So this is huge in pediatrics, whereby just a simple distraction, right, can help with the child's pain. We, as I mentioned, have child life workers, but I appreciate that not every hospital would have those resources. So, that's something that afterwards, if you're interested, and I know, we've been asked that before, like what are some other things that we could use if we don't have people like child life. So our secondary exam, so this is your sample history. I'll just sort of pull out sort of the basics of this. So allergies are a big one, right? Like I've been in cases where it's a seasoned kid and they're allergic to Ativan, and they have a history of seizures, right? And it kind of like, oh, wait a second, that would be the first drug we'd go to give. But this case, they're allergic. Past medical history, past surgical history is very important, right? Did we try to get this without using language line, right? So I'm not sure if at your hospitals you have access to interpreters. Here at Sick Kids, we have kind of like an iPad on wheels that we would pull up in triage to get that history, right? And to consent, right? Of course, in your case, obviously, if it's an emergency, then it's implied consent, but you do want to make sure that the family, you're speaking to them in the language that they're comfortable with, so that they understand the gravity of what's about to happen if it's not an emergency, or even if it was, that they understand what happened in the operating room. Last meal eaten, like we all know that, of course, sometimes we have to do RSI, so rapid sequence intubation. And then things such as like the events leading up to the illness or injury, right? To help us piece it all together. Our head to toe, right? So this is really important to be doing this. Obviously, things such as our iliac crest, if those, or pelvis, if they're not stable, then they need to have a pelvic binder, and you want to have that on if they're coming to you to the OR. Sometimes we'll see EMS roll in and they have a sheet that's just kind of pulled at the pelvis, which is not, I don't know if anyone's worn a pelvic binder. I've put one on before just for training, and it really pulls you in because you can lose so much blood into your pelvis, right? Just to kind of stress that when they come to the OR, just know that perhaps things were expedited really fast. Time is brain, right? The golden hour of trauma. We might have rushed them to your OR. but you have to think, okay, hold on a second. Yeah, maybe we should get a pelvic binder on, or yeah, let's put that, long bone femur fracture in traction, right? So just to dot your I's, cross your T's. Inspect posterior surfaces, right? Like, so was a log roll done? Is there an entrance wound to the stabbing on their back? So really just doing that cross check, because you have to appreciate that in the ER, it's challenging, right? We could be getting back to back to back traumas, very sick patients. So just to kind of go over this, and not to assume that the injury they're coming to you with is the only injury. Perhaps there's something else that's being masked. I won't go into too much detail here. It really was just to sort of, know that a lot of our traumas that we see are head traumas and abdominal traumas. So when I taught at U of T, their P's course, I would show a picture of my niece. She's now 11, of her, and you'd see her big, big belly, right? And it's because, toddlers, they haven't grown into their ribs, right? So things like their stomach, their spleen, their pancreas, their liver, it's all exposed. So when they're in a trauma, they're going to have a splenic laceration or liver lac, and they're going to bleed a lot, right? Whereas adults are, we've grown into our ribs. So that's like our armor to protect our abdominal organs. So looking to see any kind of distension or bruising on the flanks, or, in emerge, we would often do, a fast or focus abdominal sonography test, right? To look for any free fluid and whatnot. But just once again, just know that this is something to pay attention to, because these are main reasons why, or main injuries caused in trauma with kids is head and abdomen. As mentioned, hypovolemia, right, is a big one for cardiac arrest in kids. We in emerge here at Sick Kids, we use a Gorlick score. So, we also, for instance, with respiratory, use what we call a PRAM score. So it's similar to a GCS, whereby it's a number. If I say to you their GCS is 6, it's going to cause your eyebrows to raise. So similar to that, our dehydration score, our PRAM score, it's an objective way to describe what we're finding with our patients. So that's just something to kind of put on your radar to discuss. Skin, obviously your patients in the OR, you're going to see all different types of things, right? Like maybe it's injuries, or maybe you're seeing some petechiae that's developing on the table, or purpura, right? So just to shout it out, call it out, so that the team is aware, if you're seeing these changes in the child's skin. And then we finish off with what we call J. So just keep reevaluating. So VIP care. So you want to always be reassessing their vitals, questioning those vitals with your critical thinking, identifying and intervening on some abnormalities, reassessing your primary constantly, right? Intervening, reassessing, communicating, and managing their pain. So just to kind of summarize in the last few minutes here, that the pediatric assessment is a systematic assessment. It's from the door view, and it's sort of about 30 seconds where you quickly look at them and you go, okay, they're sick for showing up, right? Let's just say that they're sick for showing up. If one of their identifiers, whether it's their general appearance, work, or breathing, or color, is off, they're sicker. And then if 2 are off or more, okay, then they're sickest, right? And in those situations, it's not, a straightforward rule, but for the most part, if 2 or more are off, you're pressing your emergency bell, or your code bell, your code pink, and because that child is quite unwell. Right. If one of them is off, you might have time to kind of assess, and then, call the team on the phone to describe. But for sure, if 2 or more are off, this child is quite unwell. And I will say that for those of you, who are familiar with, PALS, hypotension is a late sign in children. Okay. So if you're seeing them hypotensive on your table, that's cause for concern. And so to call that out, but essentially anyone under, 1 month of age, the lowest and what would be considered hypotension for those under 1 month would be 60 systolic. From 1 month to 1 year, hypotension would be defined as 70 systolic. And then from 1 year up to 10, we would say 2 times the age plus 70 would be considered hypotensive. So the 3-year-old, 2 times the age would be 6 plus 70. So 76 systolic for a 3-year-old would be considered hypotension. And like I said, that's a late sign. Just remembering primary assessment is your A, B, C, D, E, F, G, and within G is the LMNOP, and then your secondary is your HI. So your history and your head to toe. So history being your sample and eye being inspect posterior surfaces. So when in doubt, correct any life threatening injury before moving on. So as mentioned, you might reprioritize from ABC to CABC if there's any extreme exsanguination or any decreased level of consciousness or no pulse or bradycardia. And as mentioned, just like with adults, right? It's pulse and rhythm. Get the pads on. Is it shockable? Yes or no? And then you're, shocking if it is, and then going through your H's and T's. So that right on time there, Alicia, 3 o'clock. So I've just got an evaluation QR code here. Welcome all your feedback. As mentioned, please, I see some little notes in the chat. So we have a few minutes to discuss a little bit further, but please know that this is not, there's so much more to talk about. I'm happy to discuss further with you all. I'm just going to pull up the chat and see if there's anything that is standing out here. So thanks, thanks so much, Christine and Michelle. And everyone else. I see Alicia, thank you so much for putting in the resources for child life. Absolutely. And as mentioned about kids health is a great one as well. If anyone wants to turn on their mic or throw in the chat if you have any questions, I think we have a few minutes.
Yes, we still do have some time for questions. If we can hang on for a little bit. And I see, Sheila, that you've asked is this will be available to rewatch. It will be. We will post the link. It takes about a week to get up the website that I posted earlier, connectedcare.sikids.ca/hospitals. It will be added in onto that website under pediatric health assessment. So it will be up there. There's lots of other resources on there that you're open to use or to review as well with your staff. And so we'll stay on for a few minutes if anyone has any questions as well for Shona. Thank you again, Shona, for.
Yeah, absolutely. Absolutely. I will say too, thanks, Josephine. We see obviously many patients right here at Sick Kids, that have complex comorbidities and whatnot. And I will say, those kiddos are at that much more increased risk of having respiratory concerns, things like sepsis is a big one, right? To identify and manage. So if you're seeing any kids like that, have a low threshold to reach out and call for help, right? Yeah. Okay, great. Perfect. And we have our team, I'm not sure if you're familiar, the ACTS team, right? That would go out and grab kids and bring them to us. Or even just, our emerge docs often will take a patch call from peripheral hospitals, right? Giving advice, right? Like in the moment while you're trying to resuscitate and while you're waiting for the team to pick them up. So reach out if you need those resources. In peds for sure, using your here at Sick Kids we have like a resus drug calculator, so you would type in their weight and then all their resuscitation drugs would show up. So I'm not sure, that comes up from community hospitals as being tricky, right? Because in adults it's okay, give 2 grams of this, give 1 milligram of epi, right? Like it's pretty quick, right? Whereas in kids, errors can happen because of needing to calculate the dosaging. So, I'm not sure what sort of pharmacy sort of resources you have. But we have a lot of, pictures and stuff in our trauma room in flip charts so that the nurses can quickly review those to help them. Things like your Broslow tape are awesome though, because it does show all your equipment sizes as well as dosaging for drugs for them. Do you post those recess drug calculations in patient rooms? Good question, Sheila. So we would have, I know up on the inpatient, they would have two sets of those sheets on their chart. And then in emerge, if we get a sick patient, a trauma or recess, our information clerk would immediately, one of their roles is to print up that sheet and bring it into the trauma nurse and put it at their bedside. We have a lot of clinical pathways and order sets, right? So, anaphylaxis, we have an order set. They would grab that and then start filling that out. If there's any specific kind of, we have a resuscitation order set for those under 28 days, for those over 28 days. We have an RSI order set, right? So it's a tool. So it's only as good as the person using it. So, but it does help because it will show you the ranges for the dose per kilo, max dose, etc.
I'm going to stop sharing quickly in case that, or sorry, not stop recording in case that
Yep.
anyone wants to ask a question that's not being recorded, then it'll give people the option. But for anyone who's viewing this in the future, thank you for viewing this.